Spend the next about 35 minutes talking about lung cancer. I started with this slide simply to show you how sadistic some of the pathologists have become when they give you this long list of classifications of lung cancer, and it's impossible to remember any of these. So what we'll do is we'll just try and simplify everything from a radiologist's perspective, and in the next few minutes, I'll basically talk about how it is that we can, as radiologists, not miss lung cancer, confirm the diagnosis whenever we suspect it, stage lung cancer well, and then a little bit about screening for lung cancer. The modalities that we use for this are X-rays, CT scan, PET-CT that has become extremely important from a staging perspective, and a bit of interventional radiology that helps us make the diagnosis. Lung cancer presents in many ways. So you can have lung cancer presenting as nodules, as consolidation, as masses, etc. But very often we make the diagnosis when we suspect it, and therefore it's very important to have a high index of suspicion each time we see something that could potentially be a lung cancer. And one way of making sure that we don't miss the possibility of lung cancer is to use a rule like this. So any focal lesion or any consolidation in a patient above the age of 35 should be regarded with suspicion for cancer. And then if we can find another diagnosis, if we can figure out that this is not cancer, so be it. If not, then we should aggressively either make the pulmonologist biopsy the lesion, or we should biopsy the lesion on our own. But the best way to pick up cancer, the best way to not miss cancer, is to make sure that we think about its possibility in every patient above the age of 35. So how does lung cancer present? It can present as a solitary pulmonary nodule or mass. It can present as a cavity. It can present with obstructive atelectasis, and it can present as non-resolving consolidation and or a bronchopneumonia. Now, when we see a lung nodule, the first thing that we are doing, intuitively or otherwise, is differentiating a benign from an indeterminate lesion. An indeterminate lesion means a lesion that is assumed to be malignant unless proven otherwise. There are three criteria for benignity that are absolute. One is the absence of growth in 2 years. So you have a nodule in April 2006 that has not grown in 2 years and 3 months, that will pretty much always be benign. If the lesion is completely calcified, as we see here, then too it will be benign. And if the lesion doesn't enhance at all, not even a little rim of enhancement should be seen. So if the lesion doesn't enhance at all, then too we would assume this to be benign unless there is a reason to call it otherwise. So these three criteria, no change over 2 years, a completely calcified nodule, and no enhancement on contrast CT or no uptake on FDG PET, provided the lesion is more than 15 millimeters for that FDG PET sign to hold, would tell us that a lesion is definitely benign. And if it is definitely benign, as per these criteria, then we can leave the lesion alone. Otherwise, we assume it to be indeterminate, and that would mean chasing it until we know for sure whether it's benign or malignant. So if we see a lesion like this that has grown in 3 months, this has a doubling, this is pretty much quadrupled in volume in about 3 months. It is an enhancing lobulated lesion. It has absolutely no criteria for benignity. We would assume this to be malignant unless proven otherwise, and basically perform a CT-guided biopsy. The same holds true for subsolid nodules. Now that we perform high-resolution and high-quality scans in virtually all patients, low dose or otherwise, we're picking up many lesions that present with ground glass attenuation focally, with or without a solid component. If these nodules are greater than 10 millimeters in diameter, we need to aggressively evaluate them with a CT-guided biopsy. If for any reason people are not willing to biopsy them, we need to follow them up. And at the end of about 3 months, if the lesion has not regressed, even if it remains the same in size, it warrants a biopsy because the index of suspicion for malignancy is especially high. The same holds true for cavities. In countries where tuberculosis is endemic, there is a tendency to call every cavity like this tuberculous, and irrespective of whether there is a AFP positivity or not, we would land up putting the patient on anti-tuberculous treatment. These kind of cavities also in patients above the age of 35, if the sputum is AFP negative, should be assumed to be malignant unless proven otherwise. And this is a patient who after 3 months on being on anti-tuberculous treatment had no improvement and actually developed a nodule along the posterior wall that eventually we biopsied and showed this to be malignant. Obstructive atelectasis is easier to look at. This is a patient who has a very famous sign that we used to learn when we didn't have CT scans with us. And you can see here the S that is formed. It used to be called the golden S sign. We have the mass here in towards the center, the obstructive atelectasis forming the other part of the S. And on the CT scan, we can see the mass occluding the right upper lobe bronchus, and this is the part of the post-obstructive atelectasis. We need to pick this up, and this would tell us for sure that centrally we have a tumor which is then producing post-obstructive collapse because of the bronchial obstruction. Here is the post-obstructive consolidation that we see here because of the bronchial obstruction. Sometimes the radiographs can show this to us. This is a scanogram that shows complete cutoff of the left main bronchus, presumably by a tumor with a complete whiteout of the lungs. And you can see the tumor very well in the center, separate from the consolidation or the post-obstructive collapse and consolidation that we see of the rest of the left lung with a loculated left pleural collection. You can also see that the tumor encases the left pulmonary artery, and it pretty much completely reduces its caliber, again telling us that we're dealing with a malignant tumor. Non-resolving consolidation can also be confounding, and we need to make sure that every patient with a consolidation is followed up to complete resolution. If the lesion doesn't resolve or it has characteristics that clinically tell us that this patient doesn't have pneumonia, we need to aggressively follow these up or evaluate them for potential malignancy. The commonest tumor that does this is a bronchoalveolar carcinoma that presents with consolidation, either lobar or as a bronchopneumonia. And as I said earlier, we need to evaluate these very, very aggressively. So what are the patterns that we see? On radiographs, we have non-specific areas of consolidation, which on the CT scan would be seen in this manner. You can see a combination of consolidation and ground glass. At first instance, we might treat these as a pneumonic consolidation, but if the patient doesn't improve, or more importantly, if the patient doesn't have fever, leukocytosis, or any of the other signs that suggest infection, we need to then aggressively biopsy these. The pulmonologist could perform a transbronchial, but we as radiologists are often aggressive and steal patients from them and perform CT-guided biopsies as well. You can see another patient with a large opacity in the right lung, which is seen as an area of consolidation. This is quite ominous because it's very rare for an infection to present with this kind of pattern. Nevertheless, clinically, it's important to check whether the patient could have infection or not, and otherwise go ahead and biopsy these. Another form of presentation of bronchoalveolar carcinoma is that of a peribronchovascular area of mixed ground glass and consolidation that we see here. Often there is a little bit of cortical sparing. This appearance can also be seen with BOOP patterns or organizing pneumonia patterns, but the clinical presentation of a BOOP pattern and that of bronchoalveolar carcinoma would be completely different. And therefore, in these patients as well, depending on the clinical situation, we would be quite aggressive about biopsying these. So these are the methods of presentation of lung cancer: lung nodules, cavities, non-resolving consolidation, or central masses with post-obstructive atelectasis. And these presentations typically form about 90 to 95% of the way in which all lung cancers present in practice. Irrespective of how they present, in the end, the diagnosis is made with some form of histopathology. And typically, either the pulmonologist does an endoscopy with a biopsy. Today, some pulmonologists and some surgeons would do thoracoscopic video-assisted biopsies. But even today, the vast majority of histopathology with peripheral lesions, with lung nodules, with non-resolving consolidation would be obtained on CT-guided biopsies. And radiologists have center stage as far as picking up and making a definitive diagnosis of lung cancer is concerned. No nodule is not biopsyable, and typically today we biopsy up to 6.5 millimeter nodules, and it's very, very easy with a combination of CT fluoroscopy and a reasonably steady hand to stick a needle inside any of these nodules. The rules to follow are that we should never do fine needle aspiration cytology. All of these should be core biopsies, and we should have at least 5 to 8 cores obtained, because not only is it important to have a diagnosis of, let's say, adenocarcinoma or squamous cell carcinoma, we then need material to do immunohistochemistry, to do mutation studies, all of which will tell us what is the kind of chemotherapy, if at all, that this patient requires for treatment. So there is a lot more material that is required, and mere diagnosis of cancer versus no cancer is no longer important. Size and morphology don't matter. If we have a subsolid nodule, it's the same procedure. We stick a needle inside using a gun cannula technique and take as many cores as possible. This is a 7.5 millimeter nodule that we biopsied. One of the tricks is to fire outside the nodule, create a little bit of hemorrhage. The hemorrhage fixes the nodule, and then we can actually pierce the nodule very well. So these are tricks that can help us get tissue out of even the smallest nodules. In patients who have central lesions, sometimes they do not agree to do biopsies. We have to make sure that we do not biopsy the periphery. It's very intuitive to stick a needle in somewhere here because we know it's safe and we will be able to get material. But if we stick a needle here, which is really the post-obstructive consolidation, we will get a negative biopsy. What we need to do is to push the needle in as centrally as possible so that we hit the tumor. And in practice, post-obstructive consolidation is like butter. When you put the needle in, there is no resistance. And the moment you touch the tumor, you get a nice, solid, gritty feeling that tells you that you're in the tumor, and that's when you can get all the biopsy material that you need. PET-CT has helped us a lot now in improving our efficacy rates of biopsy, because it will also tell us where to put the needle in. For example, this patient had 3 prior needlings done through the center of the lesion, all of which were negative. We did the PET-CT first, found out that the solid areas were at the periphery, and then went and biopsied this area that turned out to be then positive. Similarly, the cavity that I showed you earlier, we went and biopsied the posterior area where there was nodularity and uptake, and you can see that here, and we got a positive result. In patients with bronchoalveolar carcinoma as well, there are certain areas on the PET-CT that would be brighter than others. So here, though this is tumor, this doesn't light up as much as the inferior part where you see a lot of activity. And it stands to reason that the most active areas would also perhaps yield better tumor tissue than the other areas, and therefore sticking a needle inside the most active part of the lesion would help us improve our yield of biopsy. So once we've picked up or had a strong suspicion for malignancy in some form or the other, hopefully as radiologists we would perform the biopsies and we've got an answer of malignancy, we need to then stage the lesion. The TNM classification is used, and as with all TNM classifications, we look at size, nodes, we look at involvement of the adjacent structures, and we look for distant metastases. But there are certain simple principles. The TNM classification only works for non-small cell carcinoma. Small cell carcinoma is only treated with chemotherapy and radiotherapy, and across board, the survival is not more than 18 to 24 months with all small cell carcinomas. It's a very poor prognosis, irrespective of the size or the extent of disease at the time of presentation. But with non-small cell carcinomas, and these include adenocarcinomas, squamous carcinomas, neuroendocrine tumors, etc., we would want to stage these tumors and identify the ones that are amenable for surgery. The only method of treatment that improves survival in lung cancer is surgery, and that is removal of tumor. If we can do this, and if the patient is a candidate for surgery, we will have a 5-year survival rate between 20 to 77%, with median survival times from 24 to about 36 months. If, however, the patient falls into a category where there is no point operating on the patient, irrespective of what we do, the 5-year survival rate approaches 0 with a median survival time of about 18 to 24 months, even with the best form of palliation, chemo or radiotherapy. The stages that are amenable for surgery are 1, 2, and 3A. The rest of them require only palliation. And I'll run through the situations where we palliate and the situations where we operate. Today, the gold standard for staging is a combination of PET-CT and a contrast MR of the brain. PET-CT is not sensitive for brain metastases, and therefore any patient who on the original or the initial CT scan of the chest has a lesion that perhaps is amenable for surgery would then undergo a PET-CT and a contrast MR of the brain. Both of these need to be done to make sure that this patient can undergo surgery or that we accurately stage the lesion. However, if on the initial CT scan, which would in any case include parts of the liver and the adrenal glands as a standard protocol for any patient with suspected lung cancer or focal lesion in the lungs, if we have metastases in the liver or in the adrenal glands or in the brain, or if we have a large lesion here that involves, in this case, the inferior pulmonary vein, or has a contralateral mediastinal node or a contralateral supraclavicular node, then all of these patients will undergo only palliative therapy and cannot undergo surgery. So all of these metastases of any sort and the presence of any of these criteria would mean that this patient is not operable and needs chemotherapy or sometimes radiotherapy. Similarly, there are other local signs that we need to look at, the local spread that would tell us whether or not this patient can undergo surgery or not. So any tumor that is central, that involves, for example, in this case, the innominate artery and completely encases the superior vena cava. A central lesion within 2 centimeters of the carina, as in this case, completely encasing the right main bronchus as well as the right pulmonary artery. A lesion that presents with malignant pericardial effusion or malignant pleural effusion, or a central lesion like this encasing and involving the left pulmonary artery. All of these lesions, again, mean that this patient can only undergo palliation and is not a candidate for surgery. A large lesion like this involving the spine, entering the epidural space, again, would not be a candidate for surgery. So these are all those situations where perhaps even on the initial CT scan, we would know that this patient cannot undergo surgery. And again, to repeat, this is metastases anywhere in the body, whether it's adrenal, liver, the opposite lung, or the brain. Central tumors within 2 centimeters of the carina encasing any of the vital structures like the bronchus, the arteries, the veins, etc. And lesions that involve large parts of the spine would not be amenable for surgery. But which are the lesions that we can operate upon? Which are the lesions that eventually therefore have some better prognosis than the others? Small tumors, T1 or T2, these would be less than, T1 tumors can be less than 2 centimeters or 3 centimeters, that's T1A and T1B. The size matters, so if you have a tumor that's 2 centimeters or smaller, without nodes, that is N0, without metastases, that's M0, the 5-year survival rate approaches 77%. If you have a 3 centimeter nodule, that is between 2 and 3 centimeters, N0, M0, the 5-year survival rate approaches about 48 to 50%, and so on and so forth. So any tumor that is less than 6 centimeters, N0, M0 would be a candidate for surgery. Any tumor more than 2 centimeters away from the carina, here you have a large tumor, but with ipsilateral lymph nodes, that would also be a candidate for surgery. The 5-year survival rate would go down to 10 to 11% with a median of about 36 months, but that's still fair enough, and that's something that we can offer the patient. Chest wall involvement is not a contraindication to surgery, provided the involvement is of 1 or 2 contiguous ribs and we don't have involvement of the spine as in this particular case. So these are all the situations where we can operate any N0, M0 with a tumor less than 6 centimeters in size that is more than 2 centimeters away from the carina, or any tumor, any T1, T2 or T3 with an N1 and M0 would be a candidate for surgery. Here are some examples that would show us how we would deal with these patients. All of them have PET CTs done. Here is a patient with a left lower lobe tumor who on the PET CT has extensive metastatic disease in the bones as well as with contralateral lymph nodes. Clearly, therefore, this patient is not a candidate for surgery. Here is another patient. This is a 3.5 centimeter lesion. It's T2. But if you look at the PET, there is nothing else. There is no lymphadenopathy that is active, and there is no metastatic disease. In all these patients, to repeat, have a contrast MR of the brain done at the same time that would tell us that there are or there aren't brain metastases. So here we have a T2N0, M0 lesion. This patient will do well after surgery and should be operated upon. Here's another patient who has a central lesion involving the left main bronchus. It is within 2 centimeters of the carina, involving the bronchus, and even though on the PET it's N0, there's no lymphadenopathy and no distant metastases, this patient is not a candidate for surgery and will not do well. Here's a patient who has a 6 centimeter or a 5 centimeter lesion, but just ipsilateral lymphadenopathy with no other evidence of adenopathy and no distant metastases. This patient is a candidate for surgery. And then we have situations like these that need to be handled with a multidisciplinary team and a cool head. This is a 50-year-old lady family physician in Mumbai who presented with a nodule on a pre-health checkup radiograph. It's less than 2 centimeters. The PET CT and the biopsy were done on the same day. It's a 3 centimeter lesion. And you can see the lesion is active. There's no lymphadenopathy at all. And we have a single hot spot in the head of the humerus. You have to look at the situation. This is a T2, if it's T2N0, M0. The 5-year survival rate is about 50% with a median of about 48 months. If this is a metastatic lesion, then it's a T2N0, M1, where pretty much the median survival will be 18 to 24 months with a 5-year survival rate that approaches 0%. What this lesion is changes everything. And this is where we need to make sure that we're aggressive enough to get an answer on what that lesion is. So we went ahead and biopsied the lesion in the head of the humerus, which was sclerotic, turned out to be metastatic disease, and this completely changed the prognosis of this lady. She was a colleague of mine, and she pretty much lasted for about 18 months post-chemotherapy, radiotherapy, and she actually forced the surgeon to get surgery done as well. Both of the head of the humerus and the lung, nothing worked. She landed up with massive lymphangitis because you pretty much can't beat the statistics or the odds virtually all the time. So that's essentially as far as lung cancer is concerned. From a radiologist's perspective, we should have a high index of suspicion in every patient with a lesion when the patient is 35 years or older, irrespective of the smoking history or any of the high-risk criteria. With that in mind, we would then be able to make sure that we don't miss malignancy. To do so, we should be good with our hands, and it's a good idea if somebody in our department or in our team is able to perform CT-guided biopsies of even the most difficult lesions, because then it allows us to prove or disprove the possibility of malignancy. Once we've proven the malignancy, we then again become important because we need to stage these lesions. If the original CT scan shows that the lesion might be operable or that the patient is a candidate for surgery, then we do a PET CT and a contrast MR of the brain. We may still do a PET CT if the patient is going in for chemotherapy to establish a baseline that would allow us to follow up these patients post-chemotherapy to look at response to treatment. Having said that, this does not improve survival and does not improve the statistics irrespective of how much that we do. Spend the last about 3 to 4 minutes talking about screening. Low-dose screening for lung cancer has become very popular in many parts of the world. We do not do this in India at this point in time because it's not funded by the government and patients would have to pay on their own. But nevertheless, there are many governments across the world that are trying to get this established. The criteria that we would use to select the patients who go in for screening would be current or former smokers who are 55 to 74 years old and who have a history of smoking of 30 pack years. This means 1 pack a day for 30 years, 2 packs a day for 15 years, or 3 packets a day for about 7.5 years or so. Only if these criteria and the presence of no or the absence of any comorbid condition that would make the diagnosis of lung cancer irrelevant. So if the patient has ischemic heart disease or cardiac failure and is going to die in 2 years, it makes no sense to pick up the presence of lung cancer because you're not going to treat it anyway. So you have to have these 3 criteria present and all of these things absent to actually enroll the patient into a lung cancer screening program. And when we do that, we have to do a low-dose CT where the MAS is 40 or less, and it's been shown now that even with this low NMAS, we are able to be very, very accurate about picking up lesions in the lungs. Not only that, we now know that apart from picking up lung nodules, we're also able to quantify the extent of emphysema. This is a nice byproduct of performing these scans, and we're also picking up a lot of subclinical interstitial lung disease that perhaps would have manifested later on, because we must remember that smoking, again, is an extremely important cause of interstitial fibrosis. And therefore, all of these things are now adding on to the value of a low-dose screening CT in smokers. The radiation dose, because this is so important, again, in some parts of the world, is less than 2 millisieverts. And depending on which side you are on, some people would argue that the cumulative dose, if you do an annual CT for 10 to 15 years, would be more than what it would be worth to actually avoid a radiation-induced malignancy. But if you're on the other side that believes that a lot of this is a lot of overhype in terms of radiation and associated malignancy, then this is not relevant. Usual CT scans, the ones that we normally perform, for example, for a regular lung lesion with a contrast enhanced study, would be in the range of about 8 millisieverts. When we do low-dose lung cancer screening, there is a standardized way of viewing these images. Typically, we get a volume scan of 1 millimeter slices at 0.5 millimeter intervals. It's a volume stack that we view on a workstation using a high-resolution algorithm, and then we MIP these images at 5 to 8 millimeters, depending on individual preference, and then keep scrolling up and down, looking at different segments in a very structured manner. And this then allows us to make sure that we don't miss nodules. Many of these are read by two people to reduce the error of missing nodules, and very often there are computer-aided programs that are used to help the radiologist pick up these nodules as well. Once nodules are picked up, the vast majority of them do turn out to be benign, but there is again a reasonably structured, though there is still a lot of work that needs to be done, but a reasonably structured way of following up these nodules and figuring out what they are, including the use of CT-guided or VATS-guided biopsies. So what we've done in the last about 35 odd minutes is we've looked at the various aspects of presentation of lung cancer, how to confirm the diagnosis, how to stage these lesions, and a couple of minutes on lung cancer screening. Thank you for your attention.